Thanks. It's great to be here, and it's just always nice to see the attendance for this course. I have a few disclosures, but no kind of financial influence or interest in this presentation. Vascular injuries associated with fractures are uncommon, probably 1%. That means if we take trauma call 100 nights a year, then we might see one, but if that's in a level 1 trauma center, it's more common in penetrating trauma. So if you're in Baltimore, Maryland, or Chicago, or some of the other cities around that sustain a lot of gunshot violence, then it is more common. It's about half, almost, of the incidence of that 1% of fractures that are related because of penetrating trauma. But when these happen, they carry a significantly associated higher mortality. In the upper extremity, it's as high as almost 7% mortality when there is a gunshot-related vascular injury or a penetrating trauma. If it's about 20% in the pelvis, and it's obviously because there's a lot of other additional organ injuries with this, but those type of injuries are significant. So that's important for us to understand. Injury patterns can range from a simple temporary spasm as a result of just a vascular response to an intimal flap, which is what we most often see in a dislocation type of injury, a blend injury, external compression from compartment syndromes or hematomas. But we're going to talk about an algorithm, as I've been asked to do. And so when there is a penetrating injury or there's a transection, those are where we have to have a lot of people involved. Our goals are to identify these quickly, to reliably and accurately evaluate these, not overcall them, but certainly undercalling is a much more morbid and mortal decision or an omission, if you will. And then coordinate treatment, because this is a team approach. Prompt recognition is critical. Successful diagnosis it requires that we have a thorough history and physical and a quickly based, very visible injury. There's a lot of excitement when there is an open vascular injury, a high index of suspicion when there isn't that blood all over the field or all over the emergency department, and then a rapid administration of care, a timely, efficient way to run through that, and that is. Our checklist manifesto, our algorithm-based aspect. And so we, as orthopedic surgeons, may not be the first people called. In a trauma center, it's a trauma team. They usually call the vascular surgeon if there's no pulse. We're going to talk about hard and soft signs, but we have to understand the fracture. We have to be able to be a consultant and an advisor when the decisions are made. If there's a dislocation, we can reduce that and then sort things out with this. And so the high-risk fractures can be upper or lower. There's penetrating trauma of all kinds. But that, remember, is the highest risk. Almost half of the vascular injuries are related to penetrating trauma. High-energy pelvic fractures, and then adjacent to joints. So when you think about the knee, the popliteal artery is fixed. It's tethered. It's not going to be getting out of the way. Whenever there's crush injuries, we have to think about compartment syndrome, and that's the external vascular injury as well. So when we think about these particular fractures, clavicle is intensely internally related to the subclavian vein. Around the elbow, supracondylar humerus also has a brachial artery similar to we talked about the popliteal. The pelvic ring has several vessels through it that are subject to tethering and such wise lacerations or injuries. Popliteal arteries, and then the tibial artery and the distal in the ankle. We don't like to see x-rays like this because we would like to see this reduced by the ED or by our residents or ourselves and not send for x-rays. But this was an x-ray of mine. This was taken in the ED. This person was so unstable and had a vascular injury. We were able to X-fix this, and I'll show you the the diagnostic studies that were done on the table to show the injury that continued. This was not a subtle intimal tear injury, but it required stabilization. We do that. Diagnosis, we actually did that too. And then stabilizing so that it can, the vascular surgeons can do their things. When it's a blunt trauma, we think about shearing or lacerations, but more oftenly, it's an intimal tear that is subtle. They'll still have pulses. With these, there's been as high a rate of amputation as 27%. This is an upper extremity typically, but a knee dislocation is one of the more common areas. So this is another one of my patients. This is a direct impact of one of Baltimore's finest with the law, and this injury was immediately responsive, and this patient was in the ED within 20 minutes of the time of injury. A direct injury laceration, exam findings not always obvious. In this case, it's an open wound. So is there blood all over the field? Does the patient have a pulse? In something like this, there may be collateral, but probably not. So if there's collateral, then you might find pulses, but they still have a high amputation rate. This was a 3D image of the angiogram, and you can see a direct laceration by the fragments of the wound. Immediate ex-fix, immediate repair, actually, and then later plating. So damage control, and that's a piece. I'm going to bring up now hard signs and soft signs. Thinking about pulsatile bleeding, expanding hematoma, thrill. I have to always describe what a thrill is. It's in this context, feeling the blood flow, rushing past your hand or listening to it. And if you've ever felt an AV shunt for dialysis, that is what a thrill is. Pulseless limb. Soft signs are harder. These are more asymmetric temperature or pulses, anatomically related nerve injury, and because they were both sustaining the same degree of trauma, and then immediate bleeding on the site or after the injury at the field. Tourniquet. This is an older picture of one of our tourniquet patients. Now tourniquets are on most emergency vehicles, and judicious tourniquet use means if it's bleeding, put a tourniquet on him, get him to the field, get him out of the field, and get him to us. We've had a body of literature from our military experience now over the last 20 years that say that there's very little complications with the immediate tourniquet application. When it's compressible hemorrhage, you save lives. And then fluid resuscitation, take care of the patient first and reevaluate, and reevaluate. Just keep thinking about this with a suspicion. So the ankle brachial index is well known. I think everyone is aware of this and knows it. Using a Doppler or using something that's sensitive for the pulse is valuable because they may still have some hypotensive constriction and you may not hear, but there may be a pulse. So having a vascular or a duplex Doppler to hear the pulses, if it is less than 1, it's not normal. If it's less than 0.9, it's very indicative of an injury, and we need to see advanced imaging. And when that does, we don't know what the injury is, but we know that it's not normal, so we have to think about that. Consult vascular and order advanced imaging. There are some advantages, but there's very little disadvantages to an ABI. It is not a very specific injury for the location, but there are times when you can't do it. So ankle pressure index is another one where you can do it on the other side and compare those pressures, but look at the ABI because usually you have an arm that you can measure with it. Duplex is here for completeness, but it's really not routinely used as diagnostic unless there's a blood clot or a thrombosis. Angiography had been the gold standard. I would submit today that CTA is our gold standard. This allows embolization. We have in-house radiology at our level 1 trauma center, but most places don't. So it's going to take hours to get everything set up. It's expensive. And unless there's a potential for embolization, then this is probably the less advantage than multi-detector CT angiography, which is less invasive, less contrast, fast, is cost-effective, and it's pretty sensitive. CTA disadvantages is it doesn't exclude all injuries, but it gets most of them. It gets the ones that are surgically significant. Surgical explorations indicated when there's a frank vascular injury, the hard signs with it, and if you have vascular injury that's not amenable to endovascular repair, which often can be stented or shunted. So here's our algorithm. It begins with physical exam. Everywhere along the way, it is a repeating physical exam. If there are strong signs in a surgical intervention, it may be us reducing a fracture. It may be in conjunction with our vascular, but that's a consult. If ABI is less than 0.9, then it's heading to advanced imaging and eventually surgical correction. Everywhere along the way, we have a conversation about who's first. There's not science. There is science showing that there really isn't a difference in amputation rates if it's orthopedics or vascular, but as 100 years ago, the Three Stooges couldn't decide it, we couldn't either. So we think about it, and we have a conversation. Non-operative options, ligation is an option in the very distal arm, legs, when there is collateral, potentially. When there's a combined injury, that's not an option because you've got to have venous outflow as well. And so that brings up temporary vascular shunts. Temporary vascular shunts have not been FDA approved, but they are very widely used in damage control. Before that, when you have a dislocation, a simple reduction can get you the pulse back, check it, recheck it, make sure it doesn't evolve into something more with it. And then temporary vascular shunting, this is my picture, and our temporary vascular shunt in a combat setting, it's damage control. Doesn't need to be FDA approved for damage control because it's a life-saving event. And Todd Rasmussen and his group showed that there was very little complications from doing these shunts. And we teach these in our damage control combat skills courses to all surgeons. So there's also a meta-analysis from one of my former residents, Justin Fowler, who looked at all the available studies. And there hasn't been anything since that's shown that we're better or vascular's better. Working together is really the key. And if you can both do it at the same time, then that's actually great. A quick X-fix, debridement so they can do a repair is the ideal. And they do a repair with vein because foreign material has a higher infection rates. So have a protocol in place. Consider each patient, restore blood flow. And if you can do it, then you're immediately getting that done. If you can't, then you can still help debride, stabilize, and prepare the situation. And the last part is any vascular repair, any vascular injury really considers a fasciotomy. They can be prophylactic and protective. The infection rates after fasciotomies, I realize that I'm sitting next to one of the world's authorities on fasciotomies here, but these are indications in the setting of a vascular injury for a fasciotomy. These are the prognostic factors which we've talked about a little bit, and I think I don't have a time measure, but I think we're out of time. So just understand, I mentioned that amputation, even in the best settings, can still have a 25 to 30% rate. Sometimes amputation is our choice, first choice, life-saving in the middle of damage control. So, okay, how are we doing on time? Done? Okay. So I will have these. I think these are available for you for the references, but thank you.